So it is just past noon. I think we'll go ahead and get started. Good afternoon and welcome to the BRIE Collaborative Implementation Webinar on Alzheimer's disease and other dementias. I am Amy Etzel, Implementation Manager with the BRIE Collaborative. Before we begin, just a few required announcements. NQUAC will accept attendance at this webinar session as a CE event. To receive credit, you just need to document your time and submit a short survey. You'll receive an email early next week with a link to the survey along with today's presentation slides and resources and a recording of today's webinar. Please remember that if you want a certificate for a credit hour, you must provide either your license number or an equivalent ID number. If you have questions about this, please contact NQUAC directly. You are all currently on mute and you will be throughout this webinar. Today's speakers would love your participation in a Q&A discussion after their presentations. If you have any comments or questions, please type them into the Q&A box at the bottom of your screen and I will use them to facilitate our Q&A session after the presentations. I will also try to monitor to the chat box, but I will be looking primarily at the Q&A box. Today's speakers declare no affiliation with or financial interest in a commercial organization that could pose a conflict of interest in the educational content of this program. Okay, I'm going to end the poll and then move into my next slide if I can get it. Great. So that ends our housekeeping portion of today. Just a quick background on the BRIE Collaborative. We are a public-private group in Washington State formed by our state legislature in 2011. Every year, we select 4 to 5 healthcare topics or services that have variation in delivery or outcomes that are used inappropriately or too often, that maybe are not used enough, or that have a patient safety issue or an equity issue that our community cannot address alone or in any other way. As you can see, we've worked on a wide variety of topics, starting with obstetrics, looking at appropriate C-sections, and developed best practices for topics such as low back pain and end-of-life care. The BRIE Collaborative started offering these monthly implementation webinars in January of this year, and so far we've primarily focused on our recommendations related to behavioral health, such as integration of behavioral health into primary care, suicide care, addiction and dependence, etc. So if this is your first webinar with us, we encourage you to look at our previous webinars. All of them, they are all available on our YouTube channel as well as on our website, and then future recordings will be uploaded to both of those places as well. So our Alzheimer's and other dementias report and recommendation was adopted in 2017 by our community. Generally, the structure of our reports and guidelines is framed around specific focus areas, and this Alzheimer's report identified 6 focus areas to frame the recommendations around, and these are highlighted here on your screen. Your presenters will be going into more detail as we get further into the webinar. As part of the BRIE's implementation efforts, I've been developing some starting ground implementation checklists as a companion resource for each of our guidelines. So here on your screen is the first page of the Alzheimer's implementation checklist, just to give you a visual of this resource. The checklist is written for clinic staff in an outpatient setting and highlights the various actionable steps clinics can take toward implementation of these focus areas, things like making sure your EHR is updated to include CPT codes to ensure proper billing, recommendations for the types of trainings care teams should have to best serve this community of patients, and then conversations care teams could have with patients and families or other caregivers around advanced care planning and palliative care, things like that. The checklist also includes links to vetted resources that our report recommends around things like guidance for communicating with seniors who are experiencing hearing loss and principles for a dignified diagnosis. I'm not going to go into a lot of further details right now on this checklist as the time is best suited for our experts who are with us today, but please feel free to reach out to me with any questions once you receive this resource next week along with our other resources from the webinar. I'd be happy to discuss further implementation strategies with anyone who could use some guidance. Okay, I am going to stop sharing now so that I can turn it over to our presenters. Just trying to get back to this. Okay, so Jamie, you can go ahead and grab this. I'm sorry, Chris, you can go ahead and grab the screen. Dr. Christopher Rhodes will be kicking us off today. He is the Associate Professor in the Department of Neurology at the University of Washington School of Medicine, where he currently serves as the primary clinical neuropsychologist for the Memory and Brain Wellness Center at Harborview. He specializes in the evaluation and rehabilitation-oriented treatment of dementia and neurodegenerative disorders, and is also the neuropsychologist for the UW Alzheimer's Disease Research Center. Dr. Rhodes currently serves as chair of the Health and Medical Subcommittee of the Dementia Action Collaborative, tasked with developing and implementing a state plan for Alzheimer's disease, as well as disseminating the standards for dementia-related healthcare in Washington state. After Dr. Rhodes, we will hear from Lynn Corti and Jamie Teuteberg. Lynn is the Aging and Long-Term Policy Manager with the Department of Social and Health Services, Aging and Long-Term Support Division. She's been involved in the field of aging and dementia care for more than 30 years, and her experience includes roles as dementia case manager, family caregiver consultant, and program manager for adult day services and specialized dementia residential care. For the past 25 years, she's worked in the planning and development of services for people with dementia and their family caregivers for Washington State's Aging and Long-Term Support Administration. Most recently, she coordinated the multi-sector effort to develop the first Washington State plan to address Alzheimer's disease and other dementias, and now coordinates the Dementia Action Collaborative supporting the plan's implementation. And then Jamie is the Life Stages Project Manager, Clinical Quality and Care Transformations with the Washington State Healthcare Authority. Jamie has over 10 years of public health experience focusing on life course, aging, and prevention work. She is focused on finding the best possible solutions for at-risk populations. And for the past 2 years, Jamie has been involved in the Dementia Action Collaborative as the dedicated staff from the Healthcare Authority. Okay, Dr. Rhodes, take it away.
All right. Thank you so much, Amy. I trust you can hear me okay and you see the slides just fine.
Yes, that is correct.
Outstanding. All right. Mission ones have been accomplished then. Well, thank you very much for the invitation, the opportunity to give you a little bit of an update on Alzheimer's disease, both from a clinical perspective as well as a state plan and kind of program perspective. It's been my pleasure to be collaborating with the Dementia Action Collaborative and the BRE specifically since 2017, the Dementia Action Collaborative and the state plan before that. And the partnership has been incredibly productive and one of the best that I've had so far professionally. So my hope today was, again, to remind you, I don't have any disclosures. It's one of the nice things about being a neuropsychologist. I did want to give you a little bit of an update, kind of focusing on the content of the BRE work that we did with some updates, and then how we have been disseminating that with a focus on primary care, but also with allied healthcare providers and specialty providers. So we'll talk very briefly about some contextual variables. We will talk about treatment and things that you in primary care, geriatrics, neurology, wherever you may be practicing, might be thinking about in terms of helping people and families live well with dementia and memory loss, and those in midlife maybe prevent developing severe dementia. We'll talk a little bit about some of the virtual and in-person programs and resources that we offer at the University of Washington Memory and Brain Wellness Center. And then I'll turn it over to my illustrious colleagues to talk more about the state plan and the Dementia Action Collaborative. I guess the only disclosure that I do have for you is that I'm a clinician primarily. I do have involvement in research and teaching, but I still identify as a clinician and work daily with people and families living with memory loss, both from a diagnostic perspective as well as a rehabilitation, neuropsychology, intervention perspective, so treatment as well. Really a pragmatist at heart. So that's kind of the way that I approach this information and thinking about working with dementia, knowing that we have a lot of folks, both as a nation, as a world, and locally here to work with as more and more people develop memory loss and dementia. So we know we've got about 5.8 million here in the United States, about 5.3 million or so are over the age of 65, and a significant proportion who are younger than 65, so early onset. But age remains the single greatest risk factor, such that by the time you hit about 85, you've got maybe upwards of a 40–45% chance of having Alzheimer's disease. you may not have Alzheimer's dementia, but you may or likely will have some of the pathological hallmarks. And you can see based on this pie chart that, again, the older you are, the higher the prevalence. And it's worthwhile also mentioning that these numbers, as a broad brushstroke, obscure some very, very important differences across culture and ethnicity. And we know that our African-American patients and families are more than twice as likely as Caucasian folks to develop Alzheimer's disease. And those with Alzheimer's disease tend to be diagnosed later. That is true for our Latinx and Hispanic families as well. And again, of course, women are still disproportionately affected by Alzheimer's disease, men more so maybe with frontotemporal dementia, vascular dementia, but some very important differences. And one of the things that we're very interested in are our American Indian, Alaska Native communities, with some preliminary data, both coming out of Kaiser and some of our work in conjunction with Washington State University, that would say the rates are probably 2 to 1 in terms of our AIAN populations compared to Caucasians, with risk factors like head injury, substance use, depression. More locally, here in Washington State, trusting that many of you who are joining us today are here in Washington, our numbers have been holding pretty steady for the last couple of years at about 120,000 people with Alzheimer's disease, still expecting about 145,000 or so by 2025. It remains the 3rd leading cause of death. We have now the 6th highest mortality rate in the United States. We had the 3rd for a number of years behind North Dakota and South Dakota. And as states have changed some of their public health accounting via listing Alzheimer's disease as a cause of death on death certificates, those numbers start to change a little bit. The numbers that are maybe most striking to me are these here in terms of who provides care. And part of the reason that we were so excited to partner with the BRIE is that as clinicians who see patients from around the state and the WWAMI region, we know there's a tremendous amount of heterogeneity in terms of how primary and specialty care providers deal with or don't deal with Alzheimer's disease. And we have a tremendous shortage of specialists, which is why people drive from Spokane or Coeur d'Alene. We get folks flying down from Alaska. And not only care providers in terms of medical, but also in the public sector, in our professional caregivers. So we have about 350,000 unpaid caregivers who provide an unpaid economy of about 5.3 billion to a tune of about 250 million in their own healthcare costs. And those of you who work with patients and families dealing with Alzheimer's disease and other dementias, you know that this takes a physical toll, an emotional toll, an economic toll. So as we thought about this as a state and coming up with a state plan that's congruent with the national plan, one of the questions that I entertained was, what happens if 10% of this workforce can no longer provide the services that they've been providing with limited, if any, training? Could the state step in and fill those gaps? And the answer, of course, is absolutely not. We're only reaching a fraction of the folks we need to reach right now. All of these things have also kind of led us to rethink memory loss, including dementia as an inevitable consequence of aging. Certainly there are things that change as we get older in terms of memory and speed of processing and other cognitive constructs, but not everybody develops dementia. And not everybody with Alzheimer's disease develops Alzheimer's dementia, which is an interesting kind of a difference, again, between the disease and the symptoms that accompany it, should the disease progress far enough. We are very interested in approaching Alzheimer's disease from a rehabilitation model and the idea of not everything is equally affected. And there are these retained strengths and resilience factors that you can capitalize on and maybe even strengthen up in midlife to aid in decreasing likelihood of progressing to more severe stages of disease. So here's the only cartoon. That's it. Enjoy it. So just a kind of very brief kind of overview, we know, again, that short-term memory changes. Your short-term memory in your 60s is not what it was going to be in your 30s or even your 50s, but it never really declines to the point of significant functional impairment. And that's true for a number of folks as they age. There is, however, a different pathway for those who develop Alzheimer's disease, where there's this gradual accumulation of the plaques and the tangles that you've probably heard plenty about. Still some controversies around the order of operations about those forming versus being maybe pathological tombstones of another process. But this is something that begins likely in midlife and then leads to significant change as those plaques and tangles progress, and there's this different course. So again, this idea that you could have the disease in your 40s or 50s with no symptoms, mild cognitive impairment or mild symptoms, but no functional impairment, or frank dementia. So again, this kind of important disentangling of where somebody might be on this disease process and what does it mean around intervention at each individual stage. And that's some of the work that we're doing at the Alzheimer's Disease Research Center. We're entering our 37th funded year this year. And just a reminder, I know many, if not all of you, likely know this already, but it's an important thing to throw into every presentation, is the difference between the disease and the kind of the description of the syndrome that comes with it. And knowing that there are many, many things that cause dementia, including Alzheimer's, which is the most common, although mixed dementia maybe is the most common in terms of co-occurring Alzheimer's and vascular, co-occurring vascular and Lewy body, or Alzheimer's and Lewy body. But helping people and patients and families understand the difference between what dementia is and what Alzheimer's disease is, and these other things that cause dementia. And this is a topic for a different presentation, but the importance of an early and accurate diagnosis includes being able to inform folks about, this is likely what you have, this is likely what you can expect based on what we know about that, as well as making sure that you're not mistaking masquerading conditions as dementia. I am not going to spend much time on this. This is really more for your reference and resources, and you will receive a copy of the slides afterwards. But I put this together just as kind of an overview of the big four in terms of prevalence, and then some of the early signs and symptoms, what parts of the cortex are changing, what are some of the associated factors. And again, as we head into things like frontotemporal dementia, which are more rare, those tend to be a little bit more genetically driven. And we've got a lot more information around things like TDP-43 and different forms of tau, as well as subtypes of FTD. We are also learning more around subtypes of Alzheimer's disease, that there are multiple pathways to Alzheimer's and likely topographical heterogeneity in terms of plaque and tangle distribution, symptom profiles, and response to treatment. So stay tuned with that. Another important concept that we've been trying to share with our primary and specialty care colleagues is that when we think about Alzheimer's disease specifically, this is a disease of many years, and depending on the age at which you're diagnosed, the stage at which you're diagnosed, this could be a 50-year disease. So in the pre-symptomatic phases, could be 10 to 15 years. You could live with MCI for anywhere between 5 to 10 years. About 10% of people per year convert to dementia due to Alzheimer's disease after a diagnosis of MCI. And then, of course, with the diagnosis of Alzheimer's dementia, you can then live for 2 to 20 years. 20 is rare. 2 is actually kind of rare too. It's still somewhere in the 10 to 12, maybe 14-year range. The further back we intervene, when we talk about interventions, the more likely these stages are to last longer. And let's see. So when we think about treatment, the idea right now, without a curative or fully effective prevention, is that we are really looking to decrease neuropathological burden through pharmacological or non-pharmacological interventions. And there's some really lovely data that would say it's a combination of those things, that the non-pharmacological things that you can help your patients and families do serve as force multipliers for some of the other treatments that are available. So by decreasing neuropathology, can't prevent plaques and tangles at this point yet, you can keep people functioning up in the pre-symptomatic or MCI phase for longer. And there is some lovely data that would suggest this is indeed the case, but it's not a one-size-fits-all, and it's certainly not a one-intervention-fits-all. So we'll get into some of the nuances of that. Much of this has been informed by the Lancet Commission, which did a lovely job of surveying everything from what do we know around prevention to end-of-life care, This was a multinational consortium that was convened back before 2017. Publication came out. One of the striking features was about 35% of all dementias can be prevented. And this is a lifespan intervention, knowing that things that are non-modifiable, like your ApoE4 status, so if you're E4, you've got a greater risk of developing Alzheimer's disease later in life. 3-4 also, 2-4 may be protective. But if we could improve education at the preschool, elementary, all the way through junior high or high school levels, this would eliminate 8% of all dementias as you build more cortical and cognitive reserve, better healthcare literacy, a few other factors. In midlife, addressing hearing loss would eliminate 9% of all dementias, and things in late life like smoking, depression, keeping people physically active, reducing social isolation, would all culminate in about 35% of dementias being preventable. And this other percentage that are potentially non-modifiable, maybe, again, you can't modify developing the dementia, but you might be able to modify the rate of progression. In this year's update, so the 2020 update was just released, and again, they are kind of disentangling this from a lifespan perspective. Early education, still around 7%, previously 8%. Hearing loss, now at 8%. Additional risk factors of traumatic brain injury and alcohol overuse identified as an additional 4% on top of what was previously known. And in late life, interesting addition of air pollution for 2%, and social isolation increasing from 2% to 4%. And this has been particularly interesting in the times of COVID, when people in adult family homes, more structured living environments, have had their routines and their interactions completely disrupted. And I can speak from an anecdotal perspective of the folks that we work with at Memory and Brain Wellness. Certainly there have been a significant amount of declines, and you hear this regularly, of this kind of precipitous decline once those things have been disrupted. So interesting to see it increase by 100% as they've revised this. I'm also interested to see more of a proportion accounted for in later life. Still important for midlife and early life, but it gives me some hope that even though you're past 65 or 75, it's not, the horse is already out of the barn. There's still plenty of things our older adults can do, even if they have MCI or pre-MCI. So 40% now instead of 35, so that's good news. So when we think about everything we know, looking at the literature about what is helpful in prevention and in intervention, and the approach that we take as clinicians at Memory and Brain, the biggest part for us is partnering with our primary care colleagues and other specialty care colleagues for treatment of modifiable risk factors in midlife. So more aggressive control of blood pressure, insulin function, glucose regulation, cholesterol, certainly getting people and keeping people moving, treating sleep disorders, and the emerging literature would say it's probably more sleep quality than quantity that may be a risk factor for either developing amyloid accumulations or exacerbating them, and working carefully on appropriate alcohol use. And also interesting to see the recommendations around servings change recently for men and women. We do a very thorough and careful job in partnership with our pharmacy colleagues and other colleagues to look at medications, including over-the-counter supplements, things like diphenhydramine, making sure our folks are getting exercise. And this, for any of you who have quote unquote prescribed exercise, it doesn't work that way. So that's part of my job as a rehabilitation neuropsychologist, is to sit down with people and say, despite your cognitive impairments, despite your orthopedic or musculoskeletal issues, where can we start? What can you do? And how can we gradually build on that to get the blood pumping in the brain kind of responding to that? Similarly, keeping people cognitively active, avoiding cognitive retirement after someone retires from work or has a transition in their living situation. I also work on cognitive rehabilitation interventions, which are helpful both from a restitution as well as a compensation standpoint. Some dietary interventions, plenty of data around the MIND diet, Mediterranean diet. Again, not a one-size-fits-all, and don't necessarily need to be radical changes in diet, but helping people make healthier choices and meal to meal, and dealing well with stress. So we have really focused on packaging all these things together and helping folks do these kind of one piece at a time to make it sustainable. And then, of course, the critical importance of staying engaged in their communities and the importance of socialization. Again, seeing the effects of that being disrupted, and also seeing some of the benefits of being able to engage in things remotely or virtually, especially with the help of a care partner. We've had pretty tremendous success with some of our virtual programs, things that people who live in Spokane or Richland couldn't engage in before, now they can, even though it's a different kind of modality. All right. Some of the other data that came out of last year's Alzheimer's International Conference and is in the process of being published is that the more of these things that you package together, these non-pharmacological interventions, the more helpful this seems to be. So if you do 4 or 5 of these things, you may still have Alzheimer's disease, but you've got about a 60% decreased chance of developing full-blown dementia. If you could do 2 or 3, that's still a 40% reduced risk. So again, you've got memory changes, you need to make accommodations, and the rules have changed, but you can still live fairly well, if not very well, despite that, and with less loss of function. I'll tell you a little bit about the programs that we have developed and that are part of the work that we did with the BRIE Collaborative around what are the best evidence-based things to plug people into and how do you replicate those around the state if you don't have all the resources we have here in the I-5 corridor or Seattle area. We have been shifting to virtual programs and services. This is our website if you're interested. Also, you can connect with our clinic, the research world, some of our other recorded didactics. We have been shifting to virtual versions of things like our caregiver forums. We offer a kind of a newly diagnosed series, Memory Loss, A Guide to Next Steps, powerful tools for caregivers. We have done some virtual garden discovery walks and some healthy brain aging seminars. We did a series of those every Wednesday and had great attendance. And we are now in the process, congruent with the governor's recommendations and the stage that we're in here, thinking about phasing things back in, like some of our resource and education days that we can do in larger settings, Strength of the Journey, which is a kind of resilience building for people with memory loss and for care partners. And we've developed some group interventions, both kind of outdoor and more kind of rehab oriented, which we're slowly starting to think about being able to phase back in, but it's, as you well know, it's tricky, especially with this population with increased risk. I want to shift gears just a little bit and talk about what we have been doing to disseminate the work that we did with the BRIE Collaborative in 2017. And I, again, had the honor of being the chair for that work group with both interdisciplinary work group as well as representative from around the state. The value of this experience was having so many people from different perspectives, including people living with dementia, family caregivers, professional caregivers, as well as behavioral neurologists, geriatricians, palliative care providers, and those who represent payers and other groups. And when we put this together, the recommendations together, we really focused on, what are the things that we'd recommend for primary care, for specialty care, for healthcare systems, around care transitions, for payers, and for employers. So, you could imagine that if you're kind of one of the sandwich generations where you've got kids that are in school and you're taking care of a parent with cognitive impairment, if your EAP program at work was well-versed in dementia and dementia resources, that would be a tremendous benefit potentially. So as happens with many of these experiences, we spent a long time coming up with recommendations and outlining what would be best case scenario, the chasm between that and where we are now, and then what are the steps that we could tangibly take to get there, to make some movement. As an example, in the primary care setting, about 45% of people with dementia have a diagnosis in their medical record. And there are many, many reasons for that, including time and lack of training, and you have to focus on so many things in primary care. It's hard to get to cognitive impairment, especially in the early stages when there isn't significant functional change. But there are all these opportunities for detecting cognitive impairment, especially for somebody with Medicare, including the Medicare annual wellness visit, which has a mandate for cognitive screening. But as with many Medicare things, there's no clear guidance around what one should do. And that's important because we serve so many different people. Again, you can't take a one size fits all, but you can have a pathway and a protocol in place with objective and validated tools where if that's abnormal, you can then set up a second visit. There are CPT codes to help reimburse this and get paid for the work that you do, especially with complex care planning for cognitive impairment. So we have been working on disseminating that, knowing that many healthcare systems and providers don't know these things are out there. And certainly then to think about, well, that's great, but how do you then integrate it into my system? How do I do this? So we looked at a couple of different ways to reach providers out in the rural parts of our state and underserved urban parts of our state, and came across Project Echo, which comes out of the University of New Mexico. And the beauty of this is really the model is one, if you're not familiar with it, is one of demonopolizing expertise and building local expertise out in communities where people are likely to go to their primary care providers. And the idea of not like telehealth, which, or telemedicine, which we now have a ton of experience with, but you're still, the quote unquote expert or the provider is treating one patient at a time. And this is really leveraging technology, the very same platform we're using right now, before we were using it this much, to move knowledge to providers out in rural settings. So there is a hub, which is your expert panel, usually associated with an academic medical center, and then spoke sites out in different places. It could be a solo practitioner, it could be a group, it could be a healthcare system. And it's really this idea of building a community of learners. So it's not just the expert panel imparting the wisdom of the experts to the remote sites and then you go do it. It's really learning from them, what are they doing well? And it's both didactic, but it's very briefly didactic, kind of a clinical pearls, very pragmatic, 15 minutes. If you're going to do cognitive screening, here are the validated tools, here are the ones that work well for primary care, here's what you do if they're abnormal, here's how you build that second visit, and then it's case-based learning. So presentation of a complicated or even a straightforward case, and then recommendations, not just from the expert panel, but from the other providers. And the beauty of this, again, is that you now have this local expertise and you've saved hours of travel, miles of travel, time, and you've got people in those communities that other providers can refer to. The other beauty of this is you can use this platform to disseminate not just medical best practices, but other programs and services. And phase 2 for this, for us, will be disseminating things like, how do you start an Alzheimer's cafe? If you were interested in a creative arts or engagement program for people with cognitive impairment, how would you do that in Yakima or Spokane? We've got some amazing things in Seattle, but again, not everybody lives in Seattle, even though it feels like that right now. So the way we have structured this is our expert or interdisciplinary hub consists of a behavioral neurologist. That's Dr. Nancy Eisenberg, formerly of Virginia Mason, now at Swedish Edmonds. A neuropsychologist, that's me. Geriatric psychiatry, which is a kind of a rotating slot that we're still trying to fill. Primary care, we have a couple of primary care folks, including Dr. Brock Gaster. We have a social worker who is fantastic, both from a clinical and a kind of a resource brokerage standpoint. We have a geriatric pharmacist from Overlake, and we've got other kind of redundant panel members as needed, or experts that will come in to do the didactic and then hang out for the case-based part. Right now, we have about 23 sites that have joined. We launched back in June, despite the pandemic, which was a truly interesting exercise. We offer free CME and CNE. That's due to the gracious funding of our state legislature, who supported this work and has supported this work. And it's second and fourth Friday from about 12:15 to 1:30. The didactic's the first 15-minute part, and then the case-based learning is the second part. And we've got solo practitioners who are in their cars, not driving, but they're participating from their phones. We've got great involvement from CHI Franciscan with multiple sites and multiple providers per site. We've got, here's a good representation of our current participants and community members. So we've got folks in Dayton, Washington, Tri-Cities, Yakima, Wenatchee at Confluence, down in Portland, although serving a number of people from Southern Washington, and then a bunch from the kind of Seattle area, including Port Orchard, Federal Way, Bainbridge Island, Port Angeles, Bellingham, and then the orange colored stars are sites that will be joining in the next few weeks. So Ferndale, Goldendale, and Spokane, with multiple sites involved in Spokane also. So it's been a really great kind of venue to deliver some of the very same things that we've just been talking about here, as well as, from a very kind of a clinic standpoint or a provider standpoint, how do you do this stuff? It all sounds great, but how do you do it in your system with your EHR, with your resources? We are going to continue to enroll. So if you as a provider, or if you know folks who would be interested in this, what I have come to appreciate is it's not the free CME or the CNE that's kind of the thing that people appreciate about this, although that's nice too. But it's really this building of a community of support. And for those of you who do dementia-related work, this is hard work, and it's often you're left with a feeling of being an island doing this work. So to have resources that you can count on, both at the session as well as in between. One of the other things that comes with this is unfettered access to myself and Dr. Eisenberg to answer questions between sessions, or if you've got another kind of a question about the case or need more resources. So that comes with the package too. Speaking of resources, I wanted to leave you with a couple things, including our website. The Memory and Brain Wellness Center, the Echo page, all of the didactics that we've done so far have been recorded and are available for free. You can watch one of them or two of them if you're interested, just to see what it looks like. The clearinghouse for most of the Dementia Action Collaborative work and other affiliated projects is on the Memory Loss Info site there. Of course, there's the Washington and Northern Idaho chapter of the Alzheimer's Association, which there's no link there, but I'm happy to, I'll modify that and send that to you. And then if you haven't already come across Momentia, when we talk about things like programs and services worth disseminating that are in the BRE work, Momentia is this really wonderful grassroots organization that created these programs and events for people with memory loss, by people with memory loss, some really cool intergenerational, arts-based, very creative stuff, and very, very kind of stress-free, user-friendly. So if you haven't checked that out, please do. And it's been great to see that spread around the state. There's Snowmentia up in Snohomish County. Whatcom County is developing something similar, Spokane. So keep an eye out, stay tuned. And these are the things that, when you render a diagnosis, and not at that time, but to be able to follow up and provide people with these things, and you're going to hear more about what's available through the Dementia Action Collaborative. These are the things that seem to make the difference for folks. It's not the Aricept prescription or the Namenda. It's getting connected to the things that they can do that keep them engaged, keep them active, all those force multipliers for the other things that we have, the tools in the toolkit. So with that, I will stop and turn it over to my colleagues. Let me stop sharing here.
Thank you so much.
Oh, my pleasure.
Great information. Jamie, let me know if you have any trouble grabbing the screen. All right, looks like you're on it. Okay, take it away.
Great. Well, thanks everyone. Thanks for the opportunity to be here today and spending the time with us. As Amy mentioned, I'm Lynn Cordy, and I work at Aging and Long-Term Support Administration, and my most recent role, and where I spend most of my time, is in the coordination of the legislatively directed development of the state Alzheimer plan, and since then, its implementation. So when the Alzheimer's plan was published in early 2016, our many partners who had helped develop it really wanted to see it implemented. The legislation actually sunset at the time that it was published, and while we had no funding, to implement the plan, we did have the commitment of this very committed group of stakeholders who had developed the plan. And all those partners wanted to stay on and continue to see the plan implemented. So we evolved ourselves into the voluntary public-private coalition, which has now become known as the Dementia Action Collaborative. So on this slide that you see now, you'll see some of our many partners. And what you'll notice is that we have representatives from a variety of organizations, like from healthcare, from the Aging Network, legal services, long-term care, associations, providers, as well as specialty organizations such as the Alzheimer's Association, the University of Washington Alzheimer's Disease Research Center, and Harborview, where Chris sits with the Memory and Brain Wellness Center. We also, I think very importantly, have a couple of very engaged legislators from the House and the Senate in our state. And I think really importantly, we've had consumers, people with dementia, and family caregivers to offer that perspective as well. So, you know, now, since the time that it was published, we were able to have some success in getting a little bit of funding. We do have staff at the 4 agencies you see to the right, including myself at Aging and Long-Term Support Administration, as well as staff at the other sites you see there, Developmental Disabilities Administration, Department of Health, Healthcare Authority, who put part of their time partly into supporting the coalition of this big group of partners, as well as bringing awareness and capability around dementia into their own agencies. So I would say that the crux of our work, the DAC work in the first years, has really been to increase awareness. So awareness not only of dementia, but of the services that are available and out there, as well as best practices for dementia care. And the DAC really strongly believes in the need to foster hope and empowerment for families and for people with dementia. One of the things that we recognized early on is there's such negative views out there around dementia. There's so much that people often, you know, that it's just so much of a burden and stigma that people often don't even want to get a diagnosis. Don't even want to ask, and a lot of times physicians don't want to give that diagnosis. So one of the things we've been trying to do is to flip the script a little bit on that, and to emphasize that with early diagnosis, you can prepare for the road ahead. And we've had several people in our group that participated who are able to live very well with dementia. And so we've been able to try to tell their stories and get that message out there. And that is one of our primary messages, is that, you know, while we can't cure dementia, there's things we can do to make their life easier. And at any point along the way, there's things, as Chris mentioned, we can do to reduce their risk for getting it, ways we can optimize their function and their ability to stay at home longer, which is really what most people want. And we can help them cope with some of the changes in memory loss. And so I will say that, you know, after working in this field for around 30 years trying to help families, I'm really just become convinced that it is this collaboration between the community, long-term care providers, and healthcare that really can help people. I mean, I don't think any of us can do that alone. So what you see on this slide here that is up is the actual report. And we did ask at the beginning how many of you are familiar with this. We know some of you haven't had a chance to look at it. So I would suggest that you go in and look at that and see, you know, what are some of the elements of these best practices? And then also to be looking at a tool that we have on our DAC website, which is sort of a distillation into sort of an algorithm, sort of flow sheet type of thing that looks at how can you as a clinical provider, you know, go from early diagnosis through the diagnostic pathway. And I think that's a really useful way to sort of pare it down into something that's a little more manageable. So that is available to support that focus area number 1 on diagnosis in the BREE standards. And then on the next slide, what you're going to see is some tools that we've developed for the second focus area in the BREE report, and that's on ongoing care and support for people with dementia. So if you look at that, at some of the tools here that we have, one of the first things we did was to create a safety kit, because a lot of concerns that people have are around things like driving or home safety. What can we do to promote safety and have a balance of independence and safety in the home? So in this safety toolkit, we do talk about how do you have conversations about driving and when to quit, how do we make the home more safe, how do we address the issue of either wandering that's already happened or potential wandering. So that can be a very useful toolkit for yourself or to share with families. The other thing you may or may not have heard about is our dementia roadmap. And this has become very popular because we had so many perspectives from our different partners that were put into this. And it's distilled down into a format where you can talk about, you know, from the very beginning, if you're worried and wondering about memory loss, all the way to late stage dementia. And at each point, it talks to families about what are some of the questions you may have, what are some of the things you can expect in the future. And then for each phase, what kind of services, like Chris was mentioning, all the things you might be able to do. It puts them into each of those stages. So here are some things you might be able to share with the family to empower them to stay more healthy and to plan ahead. And so I think it's a really useful guide. If you're not yet familiar with the dementia roadmap, you'll find on our website and some materials that will show you on how you can order that. You can get that in hard copy or online. And then on the next slide, Jamie, yeah, I just want to share with you, you know, when we were developing the plan, at the listening sessions, we just had people say, wow, it'd be really nice if there was somebody I could call and talk to about some of these behaviors or the changes or what I'm seeing. It'd be great if I, you know, had some education. And the sad thing about that is that we already have those services. They're out there. They're available for people, but people don't know about them. And so when we ask people, well, where would you go to get this information? Do you know who they want to know from? They want to know from you. The people they trust are primary care providers. You all are their most trusted source of information. So we started thinking, you know, this is the way we need to help empower you all to share these resources that are out there for families. So what you see on the screen are the two things that over the years I've just found are that if I had to give anybody pieces of information, these are the two resources I would send them to. One would be the Alzheimer's Association. We have the number there, and the website. They're very good. They have a 24/7 helpline. They can get information about behaviors, about symptoms, you know, information they have to need to make decisions. If you want to know about services, I think the best resource is really to direct them to their local area agency on aging. And you can find that through the number. If you go to the number that's up on the screen, that would take a family to their local area agency on aging. So you don't even need to know the number. You just need to know this one number. So these are the two that I would spend my time sharing. You know, if you had the roadmap and you had these pieces of information, I think that gives you a lot of information that you can share with families to empower them. Okay, and then with that, I think Jamie's gonna pick up here.
So good afternoon, everybody. Jamie Tudeberg with the Healthcare Authority, as well as with the Dementia Action Collaborative. I'm going to share with you a few more resources. This particular one that you're seeing on your screen right now really focuses on our focus area number 3, which is advanced care, planning, and palliative care. So this is a really great tool. It's a PDF toolkit that is available in a variety of languages, including English, Chinese, French, and Spanish. And it's really there to help families and providers have difficult conversations when there are loved ones or patients with Alzheimer's disease or other dementias. So the link is there. And again, when you get the slides, you'll be able just to hyperlink it. Really great tool for you to use in practice or to be able to hand off to families. Some other tools that we have, this is one of our latest tools around that legal piece, is promoting early legal planning. So this Dementia Legal Planning Toolkit was developed by lawyers with input from a wide variety of voices from within our DAC, which includes families who have experienced dementia in their own family. Really, the impetus around creating this is we've heard from many families of people with dementia who have to make those really difficult decisions, and the decision ends up being something that their loved one may or may not have wanted to go with, but they're at a point where those decisions have to be made. So this is a dementia-focused legal planning toolkit. It talks a lot about all those bullets you see there, the dementia and capacity, financial decisions. It's a really nice, concise documents that pull all the pieces together, so you're not having to go and figure out what next you need to do. There are a number of community webinars that are coming up. Those dates are listed there. If you're interested in learning more about those, we're happy to share that. Go ahead and just put that you're interested in the chat box, and Lynn and I will make sure you get connected to those. Each of those community webinars will feature not only a lawyer that worked on this project, but in addition, a different voice from the community Dr. Nancy Eisenberg, who Dr. Rhodes recently referred to in his talk. She's talking on one of these community webinars as well. And they, again, just like the Dementia Roadmap, the Dementia Legal Planning Toolkit is available in print and online. So if you'd like to receive it in print for your practice and your patients, you can go ahead and email Meredith Gregg there. This next piece circles back to early diagnosis and how important early diagnosis is. Within the last year or so, the Dementia Action Collaborative has put together 6 mini videos. They range between 1.5 minutes to about 4.5 minutes each. And it's really a great tool as providers, as well as folks who are entering the world with dementia with a loved one. I'd encourage each of you to take a little bit of time, sometime in the next couple of weeks, to go to the website and view these. It's a great way to hear from Washingtonians who experience and are experiencing dementia in their life right now, and different ways that they're able to live with and cope with. And some of them also have their care partners in the videos as well. So a really great firsthand video that you can view, as well as you can share these in whatever way you think would be most beneficial to the folks that you serve. And then I wanted to share with you today just a few current and future efforts. I'm trying to go fast because I know we will have some questions here. So these are some current as well as future efforts that our Dementia Action Collaborative is working on. So we have a number of educational opportunities. Project ECHO is listed there. Chris already shared with you about Project ECHO. And in addition, for those folks who are and are not involved in Project ECHO, we have a number of provider education pieces that are being developed right now. Anywhere from a matrix of the variety of provider education opportunities that exist, either free or low cost across the country, and what their focus area is. Dementia is such a big subject area, and we can't take one hour webinar and tell you everything you need to know. So there's all sorts of different things that you will encounter in that matrix, and we are working on putting that together now. In addition, we are working on some additional clinical provider practice tools. So similar to that algorithm tool that Lynn showed just a few moments ago, we're working on another one of those. And so that again will be available in the coming year or so. And then our future efforts that we are working to stand up here in the next few weeks is we are putting together a care transitions project team. And really the focus of that is to find a way to increase awareness among primary care providers as well as care partners to decrease potentially avoidable emergency room visits, hospital admissions, and readmissions, with really the focus and importance on that communication and partnership between the clinician as well as the care partners. And then the other focus of that group is also to seek best practice dementia capable models to minimize those care transitions. Again, to give the best case and best experience for the person living with dementia as well as their care partner. That was a lot. That is a lot of opportunities, future opportunities that we crammed into just a few moments. There is a follow-up survey that Amy will be sending to find out how you best want to learn about those. So please just take a moment when you do get that, and that will help inform us and make sure that you are connected with these efforts. If anybody has any questions for Lynn or I or Chris, please feel free to put those in now. Thank you.
Great, thank you all. We've received just a few questions, so please, everyone out there, please do enter some questions into the Q&A box. If you put anything in the chat box, if you're able to put it into the Q&A just for tracking purposes, that would be great, but I'll try to check both as I move forward. The first question we had is, are there any conversations going on about how COVID might increase the lifetime risk of dementia due to vascular effects?
Absolutely. As a matter of fact, if I can share my screen here for a second. Actually, I don't need to. There are a number of different organizations around the world that are looking at, how might this play out in 10 years, 15 years, 20 years, and through what mechanism. One of the things that's happening right now at the University of Washington is we are transitioning chairs in the Department of Neurology. And one of the recent candidates is from Yale University, Dr. Serena Spudic, who did a really lovely talk about, she's an infectious disease, neuroinfectious disease researcher and clinician, and addressed some of these issues from a theoretical and early data standpoint. So stay tuned. I know there's some folks over at the University of Exeter, I think also, that are looking at how do we track this and look at what it means, again, 5-10 years down the road for folks. So yeah, early days, obviously, but I'm sure even in the next year or two, you'll see much more about this. Yeah.
Yeah. Lynn or Jamie, anything to add there? No. Yeah, that was a pretty exhaustive response. I'm not seeing any other questions. Is there anything that the three of you would like to add in? We have about 4 minutes left that you weren't able to cover in any of your presentations.
I did answer one question. I typed it and it looks like it moved it over. It moved it over to the answered section. So Pamela Davies had asked, and thank you. It's always my pleasure. I could talk about this stuff for hours. That's probably okay. But if you're interested in participating with ECHO, I put in the email address for our program manager. It is on the ECHO page, but it's kind of buried on the side. So I just made myself a note to make it clearer how to contact us if you are interested. You can always contact me too. You can email me.
And I can also include that as a resource when I send out the email on Monday with all of our resources. And then we did have a comment that someone was interested in the community webinars. And so Lynn or Jamie, if you could just email me a link to some of those, I will include that in the follow-up email as well.
We definitely will get that to you. And those of you who are requesting the legal planning toolkit or the dementia roadmap, please know that that will be as part of your resources as to how you can order those hard copy for your practices.
Great. And I will say that most of the links shared are included in the resource section of the implementation checklist that I showed you as well. So you'll have a lot of those resources readily available when the email gets sent out on Monday. Pamela Davies, oh, Lynn, go ahead.
Oh, I just wanted to make a comment. Somebody made a comment about the dementia roadmap being useful in their office. And one of the things that I have found, I've had both case managers and health providers comment when they're requesting these, that they're able to use the roadmap as sort of just a conversation piece with families and use it to sort of pinpoint, where is somebody in this, and then use it to literally walk through, here are some things you could be doing right now. So I think it's a resource for you as well as the family. Mm-hmm. So I just wanted to remind people of that. So thank you for making that comment. The other last thing that I did want to bring up is that we do have our very first dementia-friendly Washington Communities Conference coming up at the end of September. It's September 29th and 30th. And a lot of the things that Chris was talking about, the things we're trying to spread more widely, like social programs, Alzheimer's cafes, ways to engage people, whether it's physically or emotionally, or just getting people together. This is the first time we've been able to do this, and so it's a virtual conference, September 29th and 30th from 9 to 12 each day, and we're pretty excited about that. We have a lot of interest, but we are trying to get people from various sectors, and if there's anybody in your healthcare community that is interested in that, I think I'm going to send that to Amy as well to send out to you all. Okay. Because it might be the kind of thing you all would be interested, or of other people who might be interested. So just want to share that.
We have one last question that I'm hoping to sneak in the last minute, asking about the difficulty of enrolling a person with dementia into hospice care. It is a challenge to determine 6 months prognosis, and they find that folks with dementia are enrolled much too late in hospice due to the uncertainty of prognosis. And the idea of Medicare hospice rules are changing. A lot to try to fit into 58 seconds.
I think I can do it. Let me give it a shot. So as far as I know, the Medicare rules are not changing. And what we focused on with the BRIE work, it's on page 25 of the BRIE collaborative, our recommendations, was really palliative care as a larger construct and hospice as a subcomponent of that, and getting people engaged with palliative care earlier And what we recommended was very congruent with the earlier work with the BRIE on the end-of-life care report and recommendations from November 2014. So we kind of piggybacked onto that.
Mhm.
But absolutely, that was a universally agreed upon thing of like, this is such a hard issue.
Yeah.
And our last, not our last one, but the two didactics before in ECHO were around advanced care planning and getting people to even fill out things like post forms and, you know, being aware of the options towards end of life.
Yep. Okay, great. I'm just going to share the screen very quickly to put in a plug for our future webinars. I just really want to thank the three of you for being with us today and sharing your expertise on this topic and all of the wealth of resources that you are sharing and will be sending to me to send out on Monday. Really, really appreciate it. For the rest of you, we'd love to have you join us on our continued implementation webinar journeys. We're having one on September 30th on racial inequities and implicit bias in healthcare. And then in honor of Suicide Prevention Month in September, as well as Back to School Month, we are trying to put together a suicide prevention for youth with some of our school-based partners toward the end of September. The date it's a little bit TBD on that. If you are not already signed up for our listserv, please do sign up. The link will be in the email that goes out on Monday, and all of our blogs and all the good BRIE related news is sent out through our listserv. And then, as always, please feel free to reach out to me with any questions or